and welcome back to the channel. I hope that everybody is doing well today. It's been a couple of weeks since I've been on here on YouTube, and that is because my children's activities and sports have fully consumed my life lately. We had activities 6 to 7 days a week, and then we caught some upper respiratory infection that's been lingering. So that's added on to it. It's been really rough actually. My 6-month-old, my daughter, this was like her first time really getting sick, which is surprising because my kids bring home so many viruses. Now she has a double ear infection. She's on amoxicillin, the whole thing. So it's been a little bit rough over here, but everybody is on the mend. Sports are, some of them are winding down, which has made my life a little bit easier. And I have a moment to get on here, which is few and far between at the time. So first, before we get into today's video, if you are new here, then hi, my name is Brittany. I am a nurse practitioner. I am also the creator of the Brittany Holzbeck NP Review. It is a complete AANP and ANCC review course, and it is accredited through the AANP. So if you take the course, you are eligible for a little over 17 continuing education credits. You don't have to be a nurse practitioner or a nurse practitioner student to take the course. You could do it if you're a nursing student or if you're a nurse as well and you are in need of those CEUs, which we know we all need to maintain our licensure. So my complete course is available on Patreon. I'll have everything linked in the description box below. There are a few different tiers available on the Patreon, so just make sure that you read the description before purchasing. Otherwise, we're going to just get into today's video. So today is going to be a part 2 of a series that I've been doing, or is it a part 3? But it is going over medications that you need to know for your nurse practitioner boards exam. And so today's video, I'm going to go over 5 medications that you have to know before going in to take your boards, and then 1 or 2 hot topics that you need to know in regards to these meds. So let's just get into the content. But really quick before we do, if you could just go ahead and like the video and subscribe to the channel, it's a free way to help me out and I really do appreciate it. All right, so the first medication that you need to know before you go take your boards is going to be Doxycycline. So this is an antibiotic. It belongs to the drug class of tetracyclines, and it is used very often. So a big indication for Doxycycline that you definitely want to be aware of is that it is the treatment of choice for tick-borne diseases. We use it both prophylactically and for the treatment of tick-borne diseases. We also use it with chlamydia, and we can also use it with severe acne. So there's a lot of indications for Doxycycline, and so you do want to be familiar with that drug class. There's a couple of things to note with this. So one, generally manufacturers recommend that we don't use tetracyclines in patients that are younger than 8 years of age, and this is due to a concern for permanent tooth staining. However, studies have actually shown that there is no increased risk of this tooth staining if it's used less than 21 days. And so definitely something to keep in mind, that if Doxycycline or another tetracycline is the treatment of choice for something in a population that's younger than 8 years of age, as long as we're using it less than 21 days, there is no increased risk for that permanent tooth staining. We're always just going to be weighing risk and benefit, and that's really an overarching theme in medicine, and it applies here and it applies in all different aspects of healthcare. And then also Doxycycline does have the increased risk of photosensitivity. And so this is a really important education point with our patients if they are using this medication, that we want them to be protecting their skin in the sun. We always want them to be doing that, but it's even more important if they're taking this medication. They can have just mild skin reactions all the way to full-blown photodermatitis, and it's of course localized to those areas that are exposed to the sun, and it usually appears shortly after their exposure to the sun. So again, it's really important that we educate them that if they're on Doxycycline or another tetracycline, that they are more vulnerable to having these reactions to sunlight, and they really want to be protecting their skin. All right, so the next medication that you definitely want to be familiar with would be Lisinopril. So Lisinopril belongs to the drug class, the ACE inhibitors. It is used as a first-line treatment for hypertension. And there's some really important points regarding this medication that you want to be familiar with. One, first and foremost, if a patient becomes pregnant while taking lisinopril or any medication that acts on that renin-angiotensin system, this can be very detrimental to the developing fetus. It can even lead to death. And so we really want to get our pregnant patients off of these immediately. So lisinopril, if they're taking it and they become pregnant, immediately we want to be stopping this agent. And there are a couple alternatives that are safer for managing blood pressure in our pregnant population. Actually, one of my patrons told me this way to remember the medications that are preferred in our pregnant women. It's the phrase "new little mama," and that stands for nifedipine, labetalol, and methyladopa. So those are the preferred options in our pregnant patients that need some kind of medication to control their blood pressure. New little mama, nifedipine, labetalol, methyladopa. In practice, I most frequently see labetalol, but if there are contraindications, we have those other options as well. But so important that if they're on lisinopril, we immediately stop that medication. And then another important point regarding lisinopril is that one possible adverse reaction is the occurrence of a dry, non-productive cough. And this happens in up to 20% of patients that are taking an ACE inhibitor or lisinopril. And this can be very uncomfortable and problematic. I have a cough right now. I would go crazy if I was constantly having this non-productive dry cough. And again, it's a relatively common adverse reaction with lisinopril. If this occurs with our patient, it's been shown that even trying a different ACE inhibitor, they're likely to have that cough again as well. And so really they recommend to just change drug classes if that occurs. And so an alternative would be the angiotensin receptor blockers, or those ARBs. Those are much less likely to cause a cough. And so it's something that we want to be familiar with, be aware of, if our patients are taking lisinopril. Generally, if they are going to experience this cough, it starts within 1 to 2 weeks of starting an ACE inhibitor, but sometimes it's been reported actually that it hasn't started with up to 6 months after starting an ACE inhibitor. So if this does happen and we discontinue the agent, typically the cough will resolve in about 1 to 4 weeks after stopping the ACE inhibitor. But again, it's been reported to take up to 3 months. So just kind of a time frame to give your patient if they are dealing with this nasty cough. Okay, so our next medication that we're gonna go over is Atorvastatin. So this belongs to the drug class statins. It's a first-line treatment for dyslipidemia. And there are a couple important points regarding Atorvastatin. One being that the use of Atorvastatin is associated with an increase in liver enzymes and the development of hepatotoxicity. So with Atorvastatin and actually fluvastatin, those are the ones that are associated most with developing hepatotoxicity. Actually, fluvastatin has the highest risk of developing liver injury, but Atorvastatin is just behind that, and it is definitely has an increased risk out of the statins for causing liver injury to our patient. And so something that we very much want to be on the lookout for. Most cases of liver injury start within about 3 months of either starting a statin or increasing their dose. However, what's wild, it is rare, but it has happened where patients have been on their statin for up to 10 years and it took that long for them to develop a liver injury. And again, I always say this, but this is why it's always so important that we're looking at our patients' medications when they're coming in and when we're trying to build their differential, because that really tells us so much about what could be going on with our patients. Once their statin dose is either reduced or discontinued, those liver enzymes typically do return to their pre-treatment levels, or at least close to their pre-treatment levels. So just important that if we are concerned for liver injury with the statin, that if we either reduce the dose or stop the medication, typically those will return back to their baseline. And then another important point with Atorvastatin is that it can actually be affected by the intake of grapefruit juice. Their Atorvastatin serum levels can actually be increased with the intake of very large amounts of grapefruit juice. So it's not so much an issue if they're having, a glass of grapefruit juice. But if they happen to love grapefruit juice and they drink it by the liter, it can be a complication. And so it's something that we just want to be educating our patients on. All right, so the next medication that we need to talk about really quick would be amlodipine. So amlodipine is a calcium channel blocker, and this is used for managing hypertension. And there are a couple of really important points regarding this medication. One being that peripheral edema is the most common adverse reaction with the use of amlodipine. And so this is, ankle, leg swelling, and obviously can be very, very bothersome to our patients. The development of peripheral edema does seem to be dose dependent. And so with those higher doses, they are 2 up to 3 times more likely to develop this swelling. For example, the 2.5 milligram to 5 milligram doses of amlodipine have significantly less risk of developing that peripheral edema versus, say, the 10 milligrams of the amlodipine. And so, like I said, this can be very bothersome to our patients, and providers are going to be oftentimes tempted to prescribe diuretics in hopes to treat that peripheral edema. But the occurrence of the peripheral edema is not a result of fluid accumulation, but actually fluid redistribution. So really prescribing diuretics will not fix this problem. Instead, the literature says, instead of adding on a diuretic and not really fixing the problem and contributing to polypharmacy, they say either reduce the dose, switch the medication class altogether, or reduce the dose and add on another agent. For example, an ACE inhibitor or an angiotensin receptor blocker. And it's believed that these antihypertensives, the ACEs and the ARBs, help with the peripheral edema because they assist in venodilation. And so those are the options if they do develop peripheral edema with the amlodipine: either reduce their dose, change agents altogether, or change drug classes altogether, or reduce the dose and add on an ACE or an ARB. All right, and so the last medication that I'm going to talk about is sildenafil. So this is a phosphodiesterase enzyme inhibitor. It's most commonly used for erectile dysfunction. And there's a couple of really important points regarding this medication that you definitely want to be familiar with. So number one, you have to know that if your patient is taking sildenafil, they cannot take nitrates. And this is because there is a pretty high risk for severe hypotension. This is such a serious risk that if a patient that is using sildenafil does develop chest pain, we actually will delay their use of nitrates for 24 hours. I actually saw this in practice when I was working as an ER nurse. We had a patient that came in with severe chest pain, and the person was not asked about their drug use, their medication use, and we were giving him nitrates in the hospital for his chest pain. His blood pressure completely tanked. It was very scary how low his blood pressure went extremely quickly, and it wasn't until after the fact that they found out that he was actually using sildenafil. And so I've seen it firsthand. It can be very, very scary. It can happen very, very quickly. So it's so important that if your patient, if you're even considering using nitrates, that you are first screening them for sildenafil and really let them know of the risk, because there might be, the patient might be apprehensive to tell you that they are using this medication, but they need to know that there is a very big risk for them if they're not honest with the medications that they're taking. Another important point regarding this medication, and kind of along the same lines, is that patients need to be warned that consumption of alcohol, especially larger quantities of alcohol, can really increase their risk of hypotension, dizziness, if they're, again, using sildenafil along with the alcohol use. Really, we want to be telling them to avoid alcohol use, but if they're going to drink very, very small amounts. Any large quantity of alcohol is really going to increase that risk. All right, well, that is going to complete today's video. Hopefully you learned a little something. Hopefully you found it helpful, especially if you're going to take your boards. I have at least a couple more of these videos in this series that I'm going to continue to upload on this channel. So definitely, if it's something that you're interested in, make sure you're subscribed so you're notified when it does happen, when I upload. Otherwise, I wish you guys nothing but the best. Don't forget to learn something new every day, and I'll talk to you soon. Bye, guys.